catch up from the last meeting. First of all, just a reminder of what I hope is a refreshed approach. We're here not to get onto each other about things that are going wrong. There are other forums on the council for doing that. We're here to make sure that everybody around the table and all of the partners can contribute to the issues that we identify and the actions that we want to take to improve the health and well-being of people in Medway. And you'll hear today a lot about work that's been going on with the community to make sure that our strategy does what it says on the tin. So I think what we will do today that we didn't do last time because we had a development session, and thank you very much to everybody who took place in that. I took part in that rather. I found it useful just to sort of steady where we are, but obviously there are people around the table at the moment who were not there. So when I've done apologies, I'm going to ask you to introduce yourselves, and I'm going to ask Steph very kindly if we identify an action that anyone can do to contribute to the issues and ideas that we identify, then we'll put that onto the agenda for next time. And upcoming, we've got, I hope, lots of good things with our trying to keep the meetings as short as possible and trying to have themes. So with that, I've got apologies from Jane Black, and Matt, you're here for her, from Donna Marriott, and I guess Leanne, you're here for Donna, from Jackie Brown, and from Paul Bentley, and I'm pleased to have Multi Varshni here today, representing the ICB. And from other attendees, we've got apologies from Jane Howard at Medway Action, apologies from the Kent Local Medical Committee, and from Adrian Richardson from KMPT. And we haven't at the moment seen substitutes for those people. And I've also got an announcement to make. We've made a change to the permanent membership of the board. Councillor Chrissy Stamp is going to be replaced on a permanent basis by Councillor Eddie Peake. So thank you, Eddie, who joined us last time. And that change has been made formally through Richard Hicks, the Chief Executive, in the normal way. Thank you. And also, Councillor Van Dyke, are you joining us on a permanent? No, she's substituting, aren't you? Yes, sorry. So the person I've left out there is Councillor Edwards, isn't it? So thank you, Zoe, for substituting for Councillor Edwards today. Right, so I'm going to start asking you to introduce yourselves, and I'll start with you, Matt, please.
Hi, I'm Matt Capper. I'm the Director of Strategy and Partnerships at Medway Foundation Trust.
There we go. Thanks for the musical introduction, Eddie. I'm Simon Curry. I'm the portfolio holder for climate change and strategic regeneration.
I'm Gary Hackwell. I'm a councillor for Rainham South East.
I'm Vicky.
Scott Elliott, Medway Council Public Health Team.
Hello, Leanne Farrick, Director of People and Deputy Chief Exec.
I'm James Williams. James Williams. I'm Director of Public Health for Medway.
Theresa Murray, Deputy Leader of the Council and Portfolio Holder for Health and Adult Services.
Stephanie Davis, Democratic Services Officer, Committee Clerk.
Zoe Van Dyke, Portfolio Holder for Business Services.
David Whiting, Deputy Director of Public Health.
Tracy Coombs, Portfolio Holder for Education.
Councillor Eddie Peake.
Multi Varshni, NHS Kent and Medway ICB, Director of Strategic Change and Population Health. Thank you.
Thank you, everybody. And this is quite an auspicious week for Medway. We've launched our local plan consultation. And among other things, I'm very clear that we want a really big contribution from health, because we're looking at the Medway and the future of Medway and the health and well-being of everybody here in its widest sense. So we very much welcome contributions in the consultation from health partners. The consultation opens on the 18th of September, so we'll be pleased to hear from all of you, either as individuals or through organisations. Thank you. I'm going to move to item 2. That's a record of the meetings held on the 13th of April and the 17th of July. Has anyone got any comments about the record of the meeting? And just to let everybody know, we had a separate report from the LGA advisor who helped us with the development session that I found useful, and I think it was circulated to members of the board. So thank you for contributions. So no comments on item 2. Any urgent matters?
Can we agree the minutes, please?
Yes, sorry, I should have done that. Helpful reminder from staff there. Can we agree those minutes then, as there's nothing arising? Okay. Thank you. And I didn't see anyone for any urgent matters. Item 4 then, declarations of disclosable pecuniary interests and other significant interests. Can I just say to the board, are you all happy that you know what you should and shouldn't disclose for this meeting? Because it's a bit different to other council meetings. And if you don't know, you can ask Steph. And she'll get the answer. She'll get the answer for you. Yes, Gary.
Yeah, just to say my wife is a public governor of Medway Hospital, just to be clear that.
Okay.
Yeah, I was a public governor of Medway Hospital, but I think I'm still on their list as a public governor, but I did resign because of other responsibilities.
I have checked, you're still showing.
Okay.
I might check that.
To item 5, the joint local health and wellbeing strategy. I'm going to ask David to say a few words by way of introduction and then invite comments for everybody. But I do remind you, a lot of work has gone into this, engaging with the community, thinking about whether the strategy is fit for purpose. And James, as you were saying, when we met yesterday with colleagues from the ICB Multi, this is sitting under as a place-based strategy for things that the ICB are doing and the outcomes that they've agreed. Okay, David, thank you.
Thank you very much. Yes, so formally, upper-tier local authorities and ICBs, integrated care boards, have a joint duty to produce a health and wellbeing strategy for their areas. And that health and wellbeing strategy is delivered through the Health and Wellbeing Board. So the joint local health and wellbeing strategy is the strategy of the Health and Wellbeing Board, of all of you here. We've had a strategy, or different strategies over the last 10 years, and we're creating a new one through this year. We started engagement work on that in January this year, so we spent quite a long time engaging with different groups and different people to get their views about what should be important, what's important for health and well-being of people in Medway, and what should be in the strategy. The strategy is very important. It informs what goes into the council plan and should also link up with the integrated care strategy, which is also being developed for the whole of Kent and Medway. So the integrated care strategy and the joint local health and wellbeing strategy have to take note of each other and be aligned. As I said, we've been doing quite a bit of engagement, and through that engagement work, some of which has been online, some of which has involved focus group discussions and a workshop, we've pulled together all of the information that people have been telling us and have identified 4 key themes with a number of different sub-themes that we've illustrated in the appendix to this paper. We are continuing to develop this work, and we've taken those sub-themes and we're now bringing them together to form a sort of more descriptive narrative description of what those key areas are under each of those four main areas. But just for this meeting, I just wanted the members of the Health and Wellbeing Board to be aware of what we've done so far What we found so far in terms of the themes that are coming out that people are telling us are important. And then over the next few weeks, we will be taking this information and actually writing the strategy, turning it into a narrative strategy. And the plan is to bring it back to the Health and Wellbeing Board at the meeting in late November. At the same time, the Health and Wellbeing Board will also receive the updated integrated care strategy. So you'll see both strategies together. You'll see how they both fit together, but also how the joint local health and wellbeing strategy highlights the things that are particularly important for Medway.
Thank you, David. That's a really helpful introduction. Can everyone see the themes graphic on Appendix 1 on page 21? That's a summation of those 4 themes and the things that sit under them. And I think it's very important, and I'm very clear. Taking the Kent and Medway in its entirety, we sit in a different place in Medway to other parts of Kent. And particularly as far as health inequality goes, we've got further to go. So when we're looking at outcomes, those outcomes have to take into account the distance that we need to travel and the resource that we need to put in to getting to the kind of agreed outcomes overall. So that's why having a very clear local strategy is particularly important. So I'll open up now for any comment.
I would like to see how far I think this has gone, particularly with the breadth of the consultation, but also with the depth as well, with the focus groups for these hard-to-reach groups of people who are quite often left out and their views aren't taken into account. So I was really pleased to see that these people have been consulted. I think the themes show what a complex and broad area that this is. So many different areas which contribute to good health in Medway, from housing, education, transport, so many different strands. And clearly it shows that we need joined up thinking across the council. So I think it's a really excellent document and an excellent starting point. I'll be really interested to see how we make sure that all our different departments do engage in this joined-up thinking and are kind of considering this amongst their other priorities, which of course they had. But thank you very much for this. I think it's a really good document.
If I can just interject before anyone else speaks, absolutely spot on with that, Tracy. And I think for your comfort and assurance, yesterday when we had the workshop with the ICB, in the group I was in anyway, education really played a big part. We were looking at giving children the best start in life. And I think we had a very positive discussion that was well understood by all of the practitioners and colleagues there about the importance of education and the way that it contributes to the extent to which someone can lead a good and healthy life. So your support in that's really valuable.
Thank you. Just to add to that point and hopefully to show the joined-up thinking, this absolutely forms part of the bedrock of the Trust's clinical strategy too. So we've taken this as, and other wider documents, the ICP one and so on, as the kind of one of the core themes and strands that runs through that too. So the aim being that actually as a core partner in this whole piece, that they all complement each other. And so actually it's really helpful to see it set out this way. I have written back actually to Hannah and others in David's team just around some small word changes. So we've got that consistency that runs through there, and something around, just as an example, around promoting self-care, for example, which is a really interesting part of that kind of lower maintenance and prevention element too. But so it's just really by way of offering assurance that actually this is part of our clinical strategy too. So really joining that up locally for Medway.
Thank you, Matt. That's good to hear. And I think particularly with that element of self-care yesterday, we talked a lot about that as well, because we talked, one of the priorities that my group chose was looking after our workforce and making sure that people feel that they can do the job that they're being asked to do in challenging circumstances. So, you know, it isn't just, we're not only concerned with those hard-to-reach groups, with people who are struggling to find a good place in their health and well-being, but also with professionals who are helping us do it all. And I think, you know, that was something that we felt very clearly we should all have a contribution.
So just, thank you. So two brief points. Firstly, I really welcome how this strategy sits and complements the ICS strategy, as we had that discussion yesterday at the ICP workshop, and there is a very clear link, and I really would like to record our thanks to the team who have worked in taking the effort to even join the governance side of things. So thank you, David, and the team for that. The second brief point is in relation to about the vulnerable populations and the focus groups that have been done. I'm sure colleagues are familiar with the Core 20+5 NHS framework, and that clearly articulates how we need to identify the plus population, as in who need more support at place level base. So the focus group approach identifies and acknowledges the efforts that have gone into identifying the plus population in Medway, and recognizes the effort that is going to go into addressing the needs of those populations. So I just again want to record that because it's a really good approach around that. So thank you.
Thank you, Malti. And again, you know, we're not just treating this as a sort of single activity. For many of those groups shown in section 3.6, other events are happening. We've got a menopause strategy coming up, answering the needs of older women. We're doing a special health and wellbeing day at the barracks. And for public health, you know, all of these groups are very important. So we're trying to make sure that this strategy is live and informed as we go along, as much as, you know, we're trying to identify outcomes. Okay. Thank you. So Simon, I'm sorry.
That's fine. Thank you. And again, I just want to sort of welcome this wholeheartedly, if I like. And I love the idea that it's health and well-being. I mean, well-being underlies strong health issues anyway, as we all are aware. And I think that you mentioned the link to the local plan as well. So important that the strategies that we produce, and you've just referred, how they connect together, so we're not sort of repeating work, but at the same time enhancing and supporting the different strategies we have. And I'm looking at the diagram that we've got. I'm reminded of the Sustainable Development Goals, the UN Sustainable Development Goals, and how this relates to that directly. Clearly, it's, you know, that you can see the roots of this kind of work in that respect. And just in particular, in the area that I'm very concerned about at the moment, in relation to the climate agenda that we've got at the moment. We declared our crisis back in 2019, but issues were well before then they're affecting. And we all understand how the climate issues affect people's health and well-being directly. So our climate strategy, which we've had for 3 years now, and it undergoes constant review and revision, and we're looking at 6 areas of Medway's environment, if you like, within that strategy at the moment: air, water, biodiversity, emissions, green growth of the economy, and knowledge and empowerment of what individuals can do to enhance it. And all of that relates to this. And the green area within the diagram is clearly designed to take that into consideration. Things like better access to green spaces, improved public transport, active travel, those sorts of things, and refitting houses. If you've got a house that's damp, you're going to be breathing in bad air and have mold in there and stuff like that. So there's a whole range of stuff there that connects to the climate agenda as well. And I think perhaps it might be worthwhile for the board to hear from the climate change team at some point in the future, just so they can do a short presentation on where they are at the moment. I think that'd be quite a useful thing. But it's a great report. Thank you.
Thank you, Simon. That's a great idea because it accords with what we were saying earlier and with what you were saying, Tracy, about the need to join some of these things up. And I think the board will very welcome the action that you've taken to ensure that we've got more people from the local community involved on the climate change group rather than just technical officers and members, which I think is quite a bold step, but a welcome one. So, yes, absolutely, Steph will certainly put that on as an action from you to make sure we get this going.
Thank you. I just want to pick up on that whole idea of prevention. I like this for this point in time. I don't think anyone can argue against those 4 key objectives, but I too am interested in how we get cross-cutting with the place-based agenda, the local plan you've already mentioned. I mean, there's a whole initiative around culture, those sorts of things, and I think maybe we need to strengthen that cross-cutting so that it actually means something in 5 years' time. You can see the way everything's developed, it's come together, etc., etc. What I would say, though, is in the blue bit in the middle, where it's got Medway as a place where help is easily available, places are connected, and people have a seamless journey through services, I'm not so keen on highlighting services as it's done here, because one of the things I learned through the COVID experience was what a tremendously strong community Medway has, the strength of our families. There weren't services and people carried on. There was an innate strength. And I think signposting people to services is the wrong way of going about it. I think we need to be focusing on the inherent strengths of our children, young people, families, and be building on the initiatives in the communities. And yes, there will be services, but they go up and down as you can afford them, what central policy initiative is. I'm just a bit weary that we're focusing there on journey through services, because you're actually triggering or promoting a service-based culture, in my view, and I think we need to be promoting the strength-based approach that Medway has and we all know and love. Thanks.
Before I come to the next speaker, which is you, Eddie, I think that's an insightful point, and since we've got a section there on services, maybe we could think about changing the sort of overall purpose there. Yeah, we've got, James is pointing out to me, we're saying support independence, but as that's got an overall purpose, maybe we could, sort of reduce the emphasis on services and improve the emphasis on community. So we'll definitely have a look at that, Leanne, and perhaps come back with a form of words. Thank you. I understand the point you're making. Eddie.
Thank you. Following on from the last speaker, am I to take it that your concern is it's all very well just signposting people, and you say, go there, and then that's it, and that's not enough? I'm wondering if that's your concern. My concern is, this is a great report, by the way, and I would like to say I'm very pleased to see the terminology or the idea behind the concept of well-being being promoted all the time, because as somebody who works in mental health, and I always think at first well-being can sound a little bit limp. What does that mean? Well, fleshing it out and giving it life, then it has meaning. Likewise with the statement of intent, all sound fantastic, but they can't just sit there. That's got to be the beginning. Now, forgive me for my ignorance. I've got to catch up with this committee. Do we undertake any kind of monitoring role? I know this is awkward because we're overlapping with other organisations, but will we have some way of measuring progress at all, please?
Answer that point before I come to James, David.
Yes, and also, can I just pick up on Leanne's point, first of all? So you're right, we do need to change that a little bit. The reason that's phrased the way it is at the moment is because part of the feedback we got from people was that when they are using services, that journey is not seamless. So it's capturing that aspect of it, but I see how it comes across as only now looking like we're trying to talk about services. So we will tweak the words, but just wanted to let you know where that came from. In terms of monitoring progress, we are developing what's called a logical framework matrix. I'm a big fan of logic models and making sure that it's actually quite straightforward, and it's been developed, and once it's been developed, I'll show it to everybody. But that makes a very strong connection between what we say we want to achieve, how we're saying we're going to achieve it, how we're saying we're going to measure that we're going to achieve it, and where we're going to get the information from to be able to measure it. And it also includes the risks and assumptions. So it makes a very strong connection between those things. So we will definitely have a clear way of being able to say, several years from now, whether or not we've actually been able to deliver on this.
Can I? Yeah. Sorry, can I just quickly say, I'm really pleased to say with these reports, you get from A to B, and I'm sitting there thinking, well, how did you get from A to B? And I'm going to just take what you say on face value. Well, actually, no, then I'm not doing my job. So if we can actually see the stages go through that, but really appreciate it. Thank you.
Did you want to? Because you were coming back on. Okay, all right. Gary then. Yep. Gary, Jane.
Well, thank you for the report and thank you for the infographic. I think the infographic is very good. It's got 4 key priorities and broken down, but it is very, very, very aspirational. I mean, some of these things we're never going to fix in 5 years, 10 years, 20 years, probably, like affordable housing for all and food for all. It's something that's very, very aspirational, some of these. So I think it's following up on what Councillor Peake was saying, that we do need the detail behind and the journey, how we're going to get there, because it's very easy to brainstorm aspirational things and say, wouldn't it be great if we could? But we really need to understand the detail. I know this is a strategy and it's the first place to start from, but I think we do need to understand the detail to know how we're going to get there and when we're going to get there.
So yeah, so again, this is where the logic model comes in. So these are aspirational, but they're important things that people tell us that we need to be addressing. So we're not going to fix them all. 5 years from now, we're not going to say this is all fixed and we move on to something else. These are going to be things that we will be dealing with over a long period of time. So what we need to say is, what is enough to say that we've been successful over a 4-year period or a 5-year period? And that's what the indicators will be pegged at.
Yeah, and I think just before I come to Simon and then finally to James again. You know, Gary, look, I understand where you're coming from. These are aspirations and they're very ambitious. Got to be ambitious for the health of our population because so many people have poor health. But we've got to be realistic as well, and don't forget that particularly in public health, this is a moving target backed up by tremendous research, award-winning research, some of it, and we've got to draw on that. And as you were saying, Eddie, make sure we share that with everybody so that people can see how near or how far we are, which is why I think it's important to say this is live. You know, we're not going to leave it on the shelf and look at it in 2 years' time. We're going to be working with it all the time. And having it here serves as a reminder that everyone around this table and our partners have signed up to it. That's the really critical bit. So Simon, and then I'll come to James definitely, because he keeps giving way to everyone.
Thank you. Yeah, at the risk, I'm sure you don't want this to be written by committee, because that would be quite difficult, but I'm just reflecting on what Gary was just saying and what's been said over there about that. And actually the outcome is what matters here. The outcome is healthier lives. And if the phrase where people have a seamless journey towards healthier lives, that would encompass, I think, what we're trying to say there. And that's the kind of outcome journey, if you like, rather than the service journey. I mean, perhaps that's something worth considering.
Taking into account what Leanne said.
Thanks, Chair. And it really is a very great and powerful debate, actually, and going back to the role of this board. One of the things that I'm hearing and now taking is, remember, board members, you will be asked to champion the delivery and ownership of some of these outcomes, because we are the people in this space that are responsible for supporting and facilitating and enabling. And I just want to make that point really clear. So, you know, the points that you make, Councillor Peake, about measurements, potentially, you could be facilitating and working alongside David and the team to look at some of those measures and to, you know, to on behalf of the board, of course, to ensure that we feel that progress is actually going in the direction that it should be going in. Bearing in mind, again, that this isn't the scrutiny forum. This is us trying to find out how we can support and challenge, but make sure that delivery moves forward. Just a couple of points in. So just in response to Leanne's points around the place-based stuff, 100% get it. We've got members of our team, and we're working out across the MT to work with our planning department, and in particular with local plans. We've got an officer. I won't put Scott on the spot, but I have done. Sits within his space, who works with our planning team, and that's quite important around place-based but spatial planning. And link back to your points as well, Councillor Curry. The mental well-being aspects of environmental issues are really important, but actually we know, because we're going to be looking at this in another space, and the CMO's referenced it, the quality of our air and things that go into our lungs impacts on our life course. You know, cardiovascular disease, one of the biggest challenges that we see, and that's been referenced, is air quality. So there is a very strong bonus for us to tackle those things in tandem. So we'll get the mental well-being aspects, but equal we'll get the physical aspects. And the final point I just want to make was around the timelines. Scott brought it to me, but I won't put him on the spot with this. We get an annual refresh, or sometimes more than an annual refresh, of the performance data, and there is quite a lot of it. And today, well, in fact, it was yesterday, Medway's now got one of the lowest smoking prevalences in the southeast, 8.9%. I'll say that again, 8.9%. Now, hopefully it's not going to be, the quick swallow and then it goes up again. But that's a fantastic achievement when you think 21% previously. And the time frame, 2012. So if you look at where we are in 2013, these are some of the sustainable things that we need to do. And the benefits now of our lower prevalence will be felt now acutely, because I've also looked at some of the data. So smoking attributable hospital admissions is now green for Medway. So that's an important thing. So people who potentially would be in Matt's place, who didn't need to be there because clearly, they're doing something, i.e. smoking, that's leading them to have an exacerbation, that means that they end up we've reduced that rate. So just think about the time frame. This isn't, for 5 years or whatever. This is a life course type thing. The families now, back to Leanne, the children that are now in households where parents, carers are not smoking, have got a better life chance. Back to David.
Yeah, sorry about that. I ought to come in with a bit of the statistical information that backs it up, talking about the place issue. Obviously, we're talking about clean air as well as smoking, but the consequence of people living longer because they've got cleaner air to breathe, which hopefully are measures that we're taking across Medway now, will lead to that. But the anti-smoking thing is leading to people living longer, and that's one of the challenges we now have in our health, in our placemaking. In the local plan, we're having to make more provision for elderly care and elderly people's homes, because we've got an older a population in Medway that's getting older, which we didn't have 12 years ago because of the smoking, partly because of that. So we're dealing with a new consequence, which is a good thing in many respects. Thank you.
I mean, that really is good news, isn't it? And I think we've got to wrap around those people who've taken that bold step, because, having never been a smoker, I know people who have tried really hard to give up, and what a journey it takes on them. So as much as, we want to encourage everybody to stop, we need to really sort of celebrate and praise them when they do, because smokers have told me over the years, when you stop, it's a different life. You get involved with a different group of people because you're not standing outside the restaurant or wherever you used to go with people who are smoking. So there's a kind of whole sort of emotional attachment, I think, to taking that step. And I'm sure that the public health team are very aware of that and make sure that people, are duly recognised for doing so. And, there's a great sort of, you were talking about this, James, weren't you, even earlier today. If we look in 4 weeks' time, I can't remember what percentage of people you said, from people who come to you today in 4 weeks' time, I think you said 60% are still smoke-free. That's pretty good going, isn't it? David, did you want to?
Just a quick follow-up on what James was saying. So James gave the percentages, but if we put it into hard numbers, did a quick calculation back in the fact packet, probably the wrong example to use, calculation. That's about 25,000 people fewer who now smoke. That's a lot of people.
Hopefully they've got more money in their pockets, because if anyone's seen the price of cigarettes, it's a huge challenge.
No, I gave up smoking in 2017, and I remember how expensive it was. Following up from what Simon said about we need to be aware of upfront about the extra cost is going to come because of the older population. I don't know if we get involved with this at all. So when I worked in care and we had CQC inspections, obviously that was focusing on the standard care, blah, blah, blah. I'm not aware of much notice being taken about the finances of the company. A lot of these companies, they register charities, but basically they're out for profit. They're not there for out of the love of their heart. There was never enough money for basics like functioning washing machines, even though you're changing people all day long. Really, a functioning kitchen. Standard of the building was appalling, and you wonder where the money goes. Well, one of the main reasons probably is the extraordinary amount of money wasted on agency staff rather than having properly trained up permanent staff. And because that is reflected in the wages they get, because it is a very demanding job. It may not be academically demanding, but nonetheless it's a demanding job. But you can earn £4 per hour more stacking shelves. So until things like that are addressed, we're always going to be fighting like a tide of not being able to get enough money to fund things for care for the elderly.
I think, Eddie, that's a really important point, and part of our work on the local plan is to make sure that we've got alternatives for people to first of all, to remain as well and independent as they can in their own homes and have, enough access to being able to downsize to a lifetime home that will work with them as they go through those changes in life. But I think in the connected communities and cohesive services and the bit about reducing policy and inequality, we've got some outcomes there that cover some of those things. And I think we want the sort of organisations that you're talking about to work with us. And if there are harsh things that we need to say to them that are barriers to those kinds of things happening, then we need to do that. And I think that actually, perhaps for you, David, and for other people, we don't see, when we have the strategy meetings, many people from private care agencies, do we? Not really. Do you want to?
Yeah, thanks, Councillor Murray. Well, so on the ICP, there is a representative from the care providers on the Integrated Care Partnership. So somebody just sits in that space. And just for reassurance, Councillor Peake, in the Integrated Care Strategy, Outcome 6 looks at workforce, and we were looking at that. So that would pick up in the main some of the issues that you've raised there. It won't clearly deal with individual organisations, but what it does say is that there is, there's an aspiration to ensure that people who live, work, engage in doing whatever it is that they're doing within Medway, and in particular that's the health and social care space. There are other providers clearly in there will be a focus for the system to enhance and to support them. But it has been picked up at the integrated care system level. The commissioning aspects, I would suggest, are potentially not for this meeting, though. I would agree.
Okay, come back, yep.
Yeah, no, that's kind of answered my question, because it's all very well having that information, and I'm grateful for what you said, but what do we do with that information? And that's me trying to now learn the role of this board. We're doing an executive overlook, I understand that, but do we pass this information on to people that can pull these people out and make them accountable?
I think if I come back and then James does. First of all, Eddie, look, the high-level representation of the sector you're referring to is on the ICB. But I think you're right, actually, in the more granular stuff that we do, such as inviting people to the refresh strategy and so on, we could have better representation. And that's something that we're prepared to look at. But for services that we commission, which is not for this meeting, but it's definitely an adult social care issue, we've got very clear expectations from our providers, and they are revisited throughout the year. And I think on pay, that is a national issue, and I've heard that too many times. We've really got to be serious about getting that equivalency between health and social care. And for what, the sort of workers that you're talking about, there's a long way to go. There's no question. There's no question. But I think we have got other forums where we need to push on that. And I think in this board, it's good that those people are remembered and recognised. And I think we could do more to hear from them when we have consultations and events. So we'll bear that in mind. Okay. Anyone else? Jane.
And just to reaffirm the support that is available for the workers that you reference. So we run, don't we, the workplace health programme, and that's delivered through my team. and we would be more than happy, and perhaps offline, to have a conversation with you about how we can actually engage with whichever organisations that you've identified, to give them a little bit more of support as to how they can support their workforce, because there's more. The money is an extremely important piece of that jigsaw, as you've referenced, but there are other things that we can do. And being Wellbeing Consultancy of the Year, I think I'll get that put in. I think we're well placed nationally to add that value to your colleagues.
In that case, I'm going to move to the recommendations to remind you at 1.1 we were being asked to comment on the key themes for the joint local health and wellbeing strategy that emerged from the consultation. And I think hopefully through Steph David, you've got enough there to pick up some of the things, and we've got some promises and actions around the table for things that we want to do, including from you, Councillor Hackwell, make sure that the monitoring is in place and you can see how we're doing. So is everyone happy with that? Is that agreed? Okay, thank you. I'm going to move on then to the next item, which is the infant feeding strategy, a really important strategy that accords with children having the best start in life. And I'm going to ask you, Scott, to introduce this to us. And thank you very much, actually, for again, the very granular work that you've done in the community to help put this strategy together and make sure that it is something that people can identify with and feel comfortable with.
Thank you. So this is the third iteration of our infant feeding strategy. As Councillor Murray's mentioned, giving every child a good start is a core priority for the Health and Wellbeing Board, and what could be more important to start than what we feed our children and our babies. What infants eat is critical to their health today, but also in the long term as well. So it actually resonates with a number of the new priorities or the new presented priorities that are potential in David's paper. When we mean infants, this strategy particularly covers around the under one category, so heavy focus on breastfeeding, responsive bottle feeding, and includes things like introducing solid foods at the right time, because a baby being introduced solid foods too early is damaging for their health short and long term. And it also covers Healthy Start, vitamin and vouchers too. Breastfeeding rates is a really important metric for this. Breastfeeding has been very challenging for us in post-COVID years particularly. Pre-COVID, we plateaued around about the 70% prevalence, so 70% of infants born at Medway Hospital had breastfeeding initiated, so started breastfeeding. But we've been consistently below that 70%, between 65 and 70 in the sort of post-COVID years. It is obviously really important we have a strategy, and this strategy has been heavily informed by our data analysis. Lots of great support from Medway Community Healthcare, Medway Foundation Trust in developing the strategy and developing the action plan, because they host our infant feeding leads for community and acute. Residents have had a heavy involvement in this. We've been speaking to our lowest breastfeeding groups, parents, mums and dads, and wider groups. Stakeholder views have been factored in. Strategy is important, but the actions are the most important part of it. And we're at a very, very exciting time of infant feeding actions. We've got Medway Foundation Trust recruiting a new specialist team of infant feeding support workers. So there'll be an expert on site able to provide that support to new infants and the parents to establish a feeding pattern, massively improving, hopefully, that drop-off we see, that initial rate. We're about to completely relaunch our Beside You normalising breastfeeding website, hoping Councillor Murray will be able to do an electronic opening of the scissors of that cabinet when we launch this strategy, and efforts to normalise breastfeeding are happening with working with businesses. And we're also evolving our peer support model. Medway Community Healthcare are doing a great job with us on their breastfeeding community clinics, moving to a more paid peer support model. All these actions contribute to our strategy goals, which you can see on page 40, and we're just bringing the paper here for board to see that. Any support offered by board partners are always welcome, because this is a real key priority for the board.
Thank you, Scott, and it's really good to see that is happening at the hospital. For me, colleagues, the worrying thing is the amount of variation and the prevalence against breastfeeding in our more deprived areas and among younger women, particularly among white working class women. And I think there are some social reasons for that. You know, it may be associated with some kind of social embarrassment. It may be associated with you know, let's face up to it, a bit of misogyny. And so the work that has been going on has involved going directly to cafes, asking the owners to be a breastfeeding friendly environment, and to other businesses. And I think that's work that's got to go on. You know, this is something that we need to speak about and, you know, talk about in a supportive and welcoming way. You know, we welcome breastfeeding, and we certainly want to resist any kind of attempts to sexualize breastfeeding, to embarrass women, and to sort of promote not just the health benefits, but the you know, the family benefits of breastfeeding are really important. You know, not having to buy baby milk, which is hugely expensive, you know, not having to do loads of kind of sterilization work. And it certainly absolutely isn't a way to exclude fathers. You know, there's a lot of myths sort of put about by some people in this space. And I think the strategy has been very clear, actually, and very pragmatic about trying to overcome those. But I think there's a role for us all, isn't there, in our families, amongst friends, out in the community, to really make sure that women feel comfortable in this situation, and that the huge variation of different types of mixed feeding and different ways of ensuring that the health benefits are there are well known to everybody. So I'll ask for comment.
I thought the research was really interesting, and I think a particular concern is that young women are very low uptake on breastfeeding. And I think the concern is, as these women get older, will attitudes change, or will we find that the 30 to 39-year-olds dip down too? So I think it's so important that we do all we can with this particular demographic to try and encourage breastfeeding, because there is that risk that attitudes won't in fact change, and that rates, which are much better with older women, actually decline as well over a period of time.
Yeah, thank you very much, and thank you. This report is really excellent, actually. I mean, it's full of a lot of detail that is going to prove extremely valuable. I just wanted to reflect on two parts of it. On page 30, you talk about and Teresa just sort of referenced it earlier, about how deprivation is a factor in this, and you refer to Luton and Wayfield, and Luton is my ward, and I imagine the Wayfield end is probably more affluent than the Luton end, and that will come out in the new stats because it's now a new ward on its own. And in that respect, I'm quite sure, I mean, Luton Primary School has 47 different languages within the school. And I imagine that the diversity of the community is probably one of the factors that's in consideration. And then page 36, where you talk about some of the factors following discussions with the residents, just whizzing down to it. You've got quite a long list of things, and in the middle of it, one of them is stress and anxiety. And I think the other one or two others, returning to work and things like that. And I think particularly in my community in Luton, those are probably really key factors. The parents are simply having to get back to work very quickly. They're living in quite deprived conditions, so there's a lot of anxiety within the household anyway. And I think those factors are out of the scope perhaps of this report, but they're factors that are affecting the health of the children for the next generation. And this is where the sort of joined up thinking that we've been talking about in terms of the health and wellbeing strategy come into play absolutely fundamentally. We will not be giving the best, by not giving the best start in life to these babies now, we're going to be paying for that as they get older, because they will be obese, they will be stressed, they will have issues around mental health, all the other things that this report highlights. That's what we're going to have to be dealing with. So I think this report is invaluable, actually, as a signpost for future issues if we don't deal with it. And it's one of the factors that we need to be dealing with. So I really welcome this. Thank you very much.
Yeah, absolute advocate for breastfeeding, but I think we also need to remember that there's a cost to the breastfeeding mothers in terms of them having access to a healthy diet whilst they're feeding their babies, and that needs to be addressed as well.
Thank you. Very interested. I'm always interested in data-driven reports because data is very important. But I am a bit concerned with when you break it down into ward and things like that I imagine there's far less babies born in Hempstead and Wigmore because of the demographic of the age of the residents than there is in Luton and Wayfield, for example. And I wonder whether percentage is the right measure to look at those, because 3 babies out of 5 being breastfed is 60% success in Hempstead and Medway, but 3 out of 100 or whatever. Percentages when you're dealing with low numbers is not a good measure. And the other thing I was very interested in the whole report, there was no mention of mothers that have C-sections. C-sections it makes the mother, disabilitates the mother in the early days when they should be latching with their babies and things, and it's very hard for young mothers that have C-sections to actually recover from a major operation, breastfeed in a new, especially if it's a first-time baby. And I wonder whether we've done any research into the difference between natural birth mothers and C-section mothers.
Thank you. Just a couple of comments and one question. I really welcome the news in relation to the infant feeding advisor based in the hospital. I think that's what I take away from that. My question related to that is, given that we know the level of inequalities, how are we going to make sure that particularly women from such areas where more support is needed are equitably supported in that secondary care setting? So it's the point of equity in the secondary care setting was what was coming through my head. The comment I really would like to make it is in relation to the wider ICS strategy. I'm really pleased to see this strategy here, and as colleagues would know, one of the outcomes in the ICS strategy is also about giving best start to children across Kent and Medway system. So what I really would, and one of the key aspects of the outcomes is about reducing health inequalities, which this strategy definitely supports and contributes to. So I would really welcome a offline conversation about how do we join things up across Kent and Medway to make sure that as a system we are responding to that outcome and not really contributing towards any other health inequalities as well, but from the ICS system perspective. So those were my comments. Thank you.
Thank you, Malti. I think in view of that, I'm going to go to you, Eddie, and then come back to Scott and James. I'm mindful that you've got lots of questions there to answer about caesarean sections, about language, about equity, and about forward-going support outside of the hospital. So, Eddie.
Yeah, thank you. This subject actually brings back memories a long time ago when my kids were babies. On page 27, it does say there are occasions where it may not be physically possible for the infant to receive breast milk. Parents and carers should not feel judged. I remember when my then wife could not breastfeed. If I remember, it's a long time ago, it was to do with pain and so on. And then when she had the conversations with health professionals, she felt very judged. Her reaction to that was not to engage in conversation. A sort of, a negative reactioning. So I do wonder what support we give to women. And my wife had sorry? That's it, thank you, that one. So all this is in the mix. So that is a question, what support do we give them? I also like to say I'm glad that men were mentioned, because I actually was a beneficiary of this situation. My wife would not get up during the night. I'm the one who's lucky to bottle feed my babies in the middle of the night. It's a great chance to catch up with the rugby, but I did skin to skin. And I think I have a bond with my kids. I didn't have anything like that with my own parents. The only time I think my parents ever physically made contact with me was at the end of corporal punishment. So there's a totally different mentality. And we've got to encourage men, change nappies, cuddle your babies. I mean, I'm going off on a tangent here, but I think all this is a very important part of the mix.
To Scott first, please, then James.
Thank you. So first question, well, first observation around will attitudes change in young women? When we did a very similar piece of research and analysis 7 years ago, we found it was our young, white, more social deprived women that were our lowest breastfeeding rate. So that is a constant pattern that we're seeing locally and nationally. So I do agree that it is a challenge. You know, if you think about cultural homogenisation for us, you know, we are kind of evolving to be the same person, which is a bit worrying. So we do need to make sure we do have a lot of focus on it, because age is the biggest determinant of this by distance and deprivation. In terms of wards, again, I agree that having 47 different languages is massively challenging in just one single ward, but it's far too easy to make a lot of assumptions. You know, the very terrible acronym BAME just makes a lot of assumptions. Everyone's the same because they haven't got, you know, white skin. And it's the same with breastfeeding, because what we found during the engagement work was we spoke to lots of families, and I remember a lady, West African lady, and she just could not get her head around the fact that you wouldn't just breastfeed. This was just so normal from her kind of country of birth, and that country has 99% prevalence. Portugal has the highest breastfeeding prevalence in Europe. Ireland has the lowest. So those 47, there can be a massive variation within there as well. I think it's just really important. Obviously, the language barriers is a real challenge, and community midwives need to find great ways of overcoming that so that everyone gets the right information in a supportive way. And going back to your point, absolutely have to make sure that language that support is given in a non-judgmental way. When someone has made a choice to bottle feed their baby, people shouldn't be frowned upon by body language or words. And there is a strict training regime that's given by our infant feeding leads, both at Medway Hospital and Medway Community Healthcare. So every professional receives annual training, and UNICEF provide that training, and we pass that on. So hopefully people's experiences are better than they were a number of years ago, because every professional is given that training. Returning to work is a really important issue, and that's wrapped up in Goal 6, making sure we don't just say this is a responsibility of the mother, good luck, you've got to breastfeed. This is a responsibility to us to create an environment for that to happen, and that might be obvious pressure saying, might be an obvious enabler saying, yes, you're allowed to go and express your bottom milk, or those softer things, that pressure to come back to work and long hours where you're away from your infant. So that does reinforce that sort of social responsibility goal. The data from the wards is an interesting issue. So obviously the wards are all the same sizes, fertility rates are different across those, but the data we looked at was a 2-year aggregated one. So we would have confidence intervals in some of that in some of those. So we could have a look at what the range is potentially, but there's no doubt that deprivation is the second biggest correlation around age. So if you get a more affluent ward at any part of the country, there's a better chance they're going to have breastfeeding rates higher. Complicated births was an area we did look at, actually. We did look at the data. So the data analysis that was done, we asked our MFT colleagues to provide us with, it's coded, includes C-sections. We also looked at multiple births. We also looked at neonatal admissions to see again there. And unsurprisingly, to say the real challenge around particularly C-sections, because obviously it takes a long time to recover. There's a wound there. Neonatal admissions, again, it could be the infant's health challenges or the mother's health challenges, or even the father's health challenges. They're not there to support them. So we did look at that data, and you won't be surprised at what the correlation is. It does remind it. And that just reinforces the necessity of the midwives, the infant feeding specialists, and the health visitors to be able to be responsive, provide a really good package of care there and then, and provide that advice. And that comes down to that targeted support. Making sure that targeted support is relevant all the time to that needs as they go in. And midwives will always go in and risk assess a situation each time they go in. No, they don't just, I've seen that person yesterday. Something could have changed, particularly in the early days of a new birth. So I asked this question when we brought this paper going through the internal rounds, and asked about special educational needs and what do we do. And I was given good assurance from the midwifery infant feeding team saying, no, we assess every client every time, and we will respond to their needs because something changes every time. Obviously, at discharge, 5 days, roughly 5 to 10 days, hands over to health visitors, and they have exactly the same approach as they go through. So, yeah, we've got some good team members, and hopefully this infant feeding specialist team will get that infant and those parents off to a good start as well, so that those midwives' jobs are a bit easier. James, anything to add to any questions I've missed?
Thanks, Scott. Just really, I think the point about the disadvantage is really important. If you look at some of the wards, they intuitively you'd think, and I'll choose one Luton and Wayfield, you know that probably the birth rate there, because it's got a younger demographic, will be much higher than some of the other ones that are higher. So when you're looking at these are all the babies that are born in that particular period. And as Scott said, what they're not doing is comparing ward against ward. You're looking at the babies that are born that are registered for people who are living in those areas. And then of those, because there are obviously more babies born in Watling's at the top there, it's the proportion of those babies that are born in that space as opposed to comparing and contrast it. But I will just reaffirm, I've done some work on this in a number of other areas, not least in Kirklees, which a very high proportion in certain areas of people from South Asia. And the breastfeeding rates are significantly high, but they're living in some of our more disadvantaged communities. So I do think you've got to just take the context of that deprivation is a marker, but it's the ethnicity stuff is actually sometimes you've got to just, that's why we've done the work, not to, just blanket everybody with the same sort of brush there. Point that Multi raised, we did have a quick discussion on this. I think we all accept that there is always ways in which we can collaborate and improve the way in which we coordinate our efforts, and we need to be doing things consistently and collaboratively across the space, and we're always going to do that. And the challenge, I think, is given the context of this strategy and the other interfaces, because we're talking about infant feeding year, but actually there's a handoff into our social care space. We've already heard about our planning and how do we actually facilitate some of the things that we haven't talked about, which are the place-based stuff, the accreditation stuff, working with businesses, working with organisations, so that workers can get the ability and flexibility to breastfeed, bring the babies into work, stuff like this. All of that are things that you need to have a place-based approach in essence, but 100% where we need to collaborate, and we do across specific issues that are common across Kent and Medway, we will do that. More than happy to have those conversations.
Thank you, everybody. Eddie, I'll come to you in a minute. I think, Scott, one of the things that you might not have mentioned, unless I misheard you, was the piece of work that you've managed to do to get paid peer supporters. So you might come back to us on that. And I think, look, there's a role here for the council to lead on this. We've got to make sure that our returning to work policy reflects all of these things, that we permit hybrid working, flexibility, facilities like a fridge to keep express milk in, those kinds of things, and make that very clear to our own staff and other people around the table from organisations. I mean, I hope that the hospital, that you definitely do that, and it's welcome news that there's the support within the hospital. But I think one of the things that we need to make sure as well is that the voluntary sector, where they're providing, activities for mums and dads and babies to come along, including our libraries, actually make sure that we've got comfortable, welcoming spaces, and that people who go along to bounce and rhyme feel that they can breastfeed a baby. So that might, from the board to you, as the recommendations are asking, be something that we need to perhaps check out. I mean, you may have checked it out already. So I'm going to come back to Scott and then to you, Matt, and then to you, Eddie, because you've had quite a lot to say. Matt hadn't had a chance to speak on this yet.
Yeah, so the pay peer support model. So we have a very good partnership with Medway Community Healthcare, and they recruit breastfeeding peer supporters, so volunteers, and they recruit from people just had given birth, so they've had that lived experience. So breastfeeding is the basic inclusion criteria. Then they provided that UNICEF baby-friendly training, and they volunteer their time. The great thing about volunteers is the passion. The challenge of volunteers, often you tend to recruit from the same sample of people, i.e. people that can afford to volunteer time. So actually having an incentive, a payment to volunteers, it might change the word volunteer to peer supporter, but that doesn't matter to us. So we are going to be moving to a paid peer support model, providing a small hourly contribution to our trained workforce, and therefore that might actually allow us to recruit some more young, white, more socially deprived people from different communities, because actually they can earn, and therefore that changes that whole dynamic, because otherwise it just becomes a thing that breastfeeding is for those, that worried well group, and not for me. So it hopefully it'll have a double-edged sword and a relatively modest investment. And the way that these two new interventions are being funded and our refresh of our Presagia website and things, we're taking advantage of the family hubs and Start for Life funding that's come available to us. So we're looking to obviously reinforce that these services are critical. So when that funding ends, we've proved the business case to the powers that be to say that workforce made a difference to this tune. It should carry on.
Thank you. And I won't say millions of this because lots has been said already and lots of good stuff. And as you quite rightly pointed out, it's something that the hospital is really superly promoting on. And we do have lots of policies around nursing mothers as well, so as you would expect. There was one thing just to throw into the mix with this really, and it's slightly more general than breastfeeding, but very much included within it. One of the things we found through our sort of women's and children's health part of the clinical strategy was a general desire, and actually when we've looked at this, it sort of correlates to what the experience was for the people that were telling us this, was over the years, there has been a slow decline in what we would recognise as parent graft, or those kind of things that prepare you for being a new parent. And it is a very much a demographic piece to this, because now those things tend to be provided through NCT and other paid-for services, which do then create a barrier to attending if you're in certain population groups as well. But actually it was something that just came out of our own research as well that's kind of made us kind of have a look at perhaps what our community midwifery offer and things like that would look like too. It's fairly embryonic thinking again, and again these are services that have kind of been around and all sorts of things as well. But I do think actually as a group it might be, that's a really interesting area because it covers so many other things. It covers infant nutrition and parent nutrition. It covers all of the usual things around caring for your baby and and all those kind of things. But there are real opportunities and touch points for the much broader health and well-being type of conversations as well. And it's probably no surprise that as those things have reduced over the years, other things start to creep up. So it's just something that to point out that sort of came out of some of our thinking too. So it's I can't give you any solutions or anything because we're still embryonically kind of thinking about it ourselves, but it is something that's kind of appeared as we were doing that research. So something maybe this group to think about.
Before you do, I mean, absolutely a very fair point, and it accords with what Zoe was saying about mothers having access to good food both before and after the birth. I mean, we have got some good examples with our blooming bumps and so on, but I quite agree with you. We do need to widen that, and I think some of the discussions that James and I have had is that even before conception, we need to get people thinking about, how to achieve a healthy conception and a healthy pregnancy, and they're things that, yes, have been neglected over the last few years.
Matt, so perhaps we can have a conversation offline, because I think you've definitely identified an area where I think there is 100% scope for further collaboration, clearly, because we commission the health visiting service. They deliver those sort of antenatal classes. We've got some bespoke programmes, as Councillor Murray's just described. But I'm even thinking broader around how we move, and I don't want to put Multi on the spot because we're doing a piece of work on women's health as part of the women's health strategy. But there is something there potentially around looking at this space and seeing where we can actually add value to that collaboration, because you've got some touch points. You've got women, families coming into that area, into the acutes, needing potentially signposting, or perhaps we can facilitate some in-house provision of some of those other services that are in existence. So we can probably pick that up, Councillor.
Okay, thank you. Eddie.
I'm just wondering out loud, have we actually been able to identify why we think there is less breastfeeding, particularly in white, poor areas? Is it economics or is it cultural? And the reason why I say this, back in the day, I can't imagine my Cockney grandparents, they did all right. It was a train driver, but they were so careful with every single penny. That's also back in the day when people like my grandmother also cooked from scratch. They didn't spend a disproportionate amount of money on takeaways and fast foods and things like this. And I'm then linking that with the almost fashion thing of people spending, so this sounds a bit judgmental, sorry, or spending a disproportionate amount of money on the most fancy, I could think, sorry, when I was working in care, working with somebody who's not in a good wage, spending a ridiculous amount of money on her pram, the latest clothes, all these things, the bottles, the feed, the steamer, all this costs a lot of money. So is it economics, or is it just a cultural thing about eating healthily? and then breastfeeding? Is there like an attitude of fashion? Is there something else going on? Have we been able to identify this at all? Please.
So I'll be very quick, and you didn't put me on the spot at all. In fact, I was thinking the same, that I must connect with you offline around that how can we make our offer to women more inclusive around the well-being. So I'll take that as an action. Thank you.
Yeah, so page 36 is probably the kind of the best starting point in terms of what is the main factor which is driving these things. Now, unlike like every other factor, there isn't a single reason. So what we try to do of our insight work, speaking to our young, white, more socially deprived parents, new parents, or just given birth or just expectant parents, rather than that long list of bullet points that's on page 36, which comes from the literature of all the UK-based studies, we wanted to ask the question, what are the dominant reasons within our Medway views, our target audience Medway groups? So then if you move down to page 37, what you'll see on that page 37 is the more dominant views. Now, if you see a plus next to knowledge of health benefits, so where there was a knowledge of health benefits being in place, plus means that was a driver, that was a factor. So the minus is the barriers. So very crudely, if you look at that's your best summary of what's the thing that's driving Medway here. Is it economics? Well, actually, it's inaccurate lack of information about the challenges. People didn't feel mums didn't necessarily feel they were given the right information and told how difficult it was going to be. The intention to breastfeed has got a plus and a minus next to it, because that is either a positive, because I intended to, I'm going to. Our market segmentation told us that if somebody decided they're going to breastfeed, they did no matter what. Come hell or high water, I've decided to breastfeed, this is what I'm going to do for my baby, because I agree, breast is best, it's going to happen. But if there wasn't an intention to feed, it became a barrier, because straight away I made that decision before I was pregnant, and we know that happens. We know that of the 100% potential market share we've got for initiation, some will have made their mind up by the age of 13 because they've always bottle-fed baby Barbie with a little bottle, and that's what they know as normal within their families. That's not right or wrong, that's just explaining it. Shyness, shame, or anger, you can see there. So people feeling shameful was a big issue. Pain, people experiencing that pain. Maybe they had a C-section, maybe they just had a difficult latch. Personal experience of physical challenges, so again, that's more around births. Non-birthing partner, feeling surplus requirements, that was a barrier. Oh, I want to get dad involved. I want to get my, same-sex partner involved. That happens. Old-fashioned values. Oh, I don't want to do that in front of granddad. That's really difficult. That's not what we all do. Breast is a problem. Over-sexualisation. Councillor Murray mentioned in the intro. This is a major issue in the Western world. Many African countries and other kind of areas would have a completely, different view on these kind of aspects. And if you went into the South America, into the jungle, you're going to find a very different attitude to clothing and arrangements, so therefore a very different view of what we think about our bodily organs. Other commitments, people being busy. Time is a massive challenge for us. Unsanitary, unsafe process. So they're the major ones. Where you see the minus, they are the most dominant things we found from our research.
No, thank you for that summarisation. You brought this table more to life. Under pride and resilience, and it's a plus, can you expand on that one, please?
So pride and resilience is when I feel proud I've done it. And it's like an ever-increasing circle. I managed to initiate, I can do this. And this is why we're looking at our messages. We know that the breast is best message is a terrible message. Only 10% like the breast is best marketing message. But actually, if we can do something like every feed matters, you've done it once, you can do it again. Don't think I've got to breastfeed my baby for a whole year. That's quite daunting. But mums and parents, and I feel really proud that I managed to breastfeed my baby. All these challenges and how difficult the world is, I feel proud I can do it. I'm resilient, I can do that. So that comes back down to establishing a pattern in the first place, to get that initial pride to then carry that on, because obviously initiation is important, but it's even better if that baby's breastfed for the 6 months up until introducing solid foods, and then ideally for the first year. So that's that pride and resilience being enabled if it's in place in the first place.
I'll try to be brief. So thank you for that as well. So we really need to try and get to a point where it's normalised.
Yes.
And the reason why I say that, and I mentioned culture earlier on, I know a little bit about Kenyan culture because my sister-in-law is Kenyan, And in that society, women will breastfeed openly, basically everywhere. On a bus, I've sat next to a woman on a regular bus, which believe me, is an experience in itself, going up mountainsides with no barriers, just openly breastfeeding, not worried about any danger zones, everywhere. It's normal because the upper part of the body is not a sexualised place of embarrassment, if you like. So I know that's not that relevant to our culture, but just, that's why I mentioned culture, and I think you've tapped out on this. I mean, not breastfeeding in front of your grandfather is most probably actually a very big factor. Thank you.
And the Beside You campaign launch is hopefully enabling that. So you'll see a lot more of that. We'll be emailing all members of the Health and Wellbeing Board to get you to encourage all places to become breastfeeding friendly. Vicky will be working around, she's had a conversation with some hot food takeaway outlets that might not complement our obesity agenda, but this is where our residents go. So we'll be asking them to commit to being breastfeeding friendly. Wetherspoons and places where our target units go, it should be normal practice. And in a McDonald's in Portugal, it would be normal.
You, Zoe.
Yeah. I don't know what work.
Sorry, that was me.
Social isolation, because I've come across groups where women get together and support each other, mentor each other. But I think for women who are struggling with it, if they're isolated as well, that's more difficult. And I don't know how we could bring that together in terms of setting up groups for people to support each other from starting in when they have their babies in hospital.
Yeah, and so our peer support networks happen, so our volunteer groups do come in. So what we need to change is that perception that is just for that cohort of people, that those worried well groups. And and the ambition obviously is to have with our paid peer support model, hopefully have a breastfeeding peer support group every day. Not even that allow us to change the venue on different days of the week, but let's be honest, if you've got a screaming infant that's 7 days old, you're not waiting until the following Wednesday to go and speak to someone, you want to see someone that, ideally that minute. So that's why the specialist team on the end of a phone would be great, because we had a phone 3 o'clock in the morning, get to speak to someone who hopefully you've already seen or remember that team. But a peer support is massive, whether it's because you're socially isolated, you've just had a heart attack, speaking to somebody that's going through the same challenge as you is just, I'd say more than halved. Problem talked about is halved in a group, halved again. So yeah, we really want to expand our peer support network and have more drop-in groups. And ideally, I have a target of moving to 1 a day, but we do need the peer supporters in place for that. And then we need the demand for those groups. It's all well and good having peer supporters willing to commit their time, but actually they're going to need to have people that want to come to those sessions. So we all have a role in promoting them in our council clinics, promoting them at hospitals, midwifery clinics, health visiting clinics, and getting those services to be able to host it in places and spaces where people go would be great. So they're seen and I know I can go to that support and it's there. So yeah, I agree.
Anyone else? So I'm going to go to the recommendations now. 1.1, we're asking to review the outcomes, and I think we've had a really good go at that. 1.2, lots of actions, I'm pleased to say, about how we collectively can come from our organisations to help deliver the recommendations. And I think, Steph, I hope you've got enough comments to be sent to Cabinet. And I think particularly I'll be asking Cabinet to make sure that the portfolio holders support this initiative within their areas across the council and making sure that we have a really good look at whether our staff feel that that's actually happening. Okay, is everyone happy with the recommendations? Right, thank you. I'm going to move on now to our item 7, whole system obesity. It's nice to have Vicky with us today. So if you'd like to introduce the paper for us.
Hello on. So yeah, obesity.
Oh, Scott's going to. Okay,
yeah, sorry,
okay,
sorry, me again. So obesity is a perfect example of a wicked system problem. So you might not have heard the term, but effectively what we're talking about with obesity being there's no single cause of obesity, and therefore there's no single solution. Hence, what we have in Medway and what's been advocated for nationally is a whole system obesity programme. So Vicky chairs a whole system obesity network. We aim to bring a multitude of partners together to deliver a suite of actions in a joined-up, efficient way. The opposite to a whole system programme is a no-system programme where people think it's a problem and go and do some action and don't take the opportunity to work in partnership and link up resource or assets or people. What this paper does, it details some of the progress we've made in the last year in terms of actions against our priorities. So this is an annual agenda item that we bring to say this is what's happened in our whole system world, and also highlight some of our key priorities for the year. One of them is our infant feeding strategy. The other one will be around our Sustainable Food Places award submission, and the third one being around developing our physical activity network. We definitely believe in the powers of network, bringing partners together, people with shared goals, so stakeholders, whether it be from the voluntary sector, educational sector, private sector, those that are interested in getting people to move more regularly. We host the Physical Activity Alliance, which is one of the subgroups, including the infant feeding and the Medway Food Partnership. And we've got just booked a new venue for our meeting in November for that one. And yeah, it's about working collaboratively. We know there's much more to do, and even though our obesity rates are, coming down, if you look at the data, we've seen progress this year, it is far too easy to not look at the x-axis and see that we've got almost 40% of our children starting secondary school above a healthy weight. 40% is far too many. So we continue to welcome all Health and Wellbeing Board partner support of our whole system obesity work, and happy to take any questions or feedback on a programme.
Vicky, would you like to add anything? No? Okay. Right, so anyone else, please? Simon?
Yeah, thank you very much. And I really obviously welcome this report and looking through the detail of it. Like you say, there's not one cause of obesity, but one thing I think might be, I have tried just again to try and spot it, is which we've mentioned a number of times, is about the quality of the air. And I think that's probably should be in here. One of the factors that causes compromised lungs in young children is the quality of the air they're breathing on the way to school every day. I mean, a good example would be Luton Road. Obviously, we've talked about Luton a few times. But even if you go up to the grammar schools at Rochester and the maths school, and the buses are sat outside the schools with their engines switched on every single day of the children's lives, they're walking out into that fog of diesel fume. That is going to affect their lungs. And as soon as the lungs are affected, they stop being active. And then when they're not active, that's when the obesity issues start to kick in, as well as all the other factors that we're aware of. So I really do feel that air pollution needs to be part and parcel of this quite strongly. And obviously that ties in. And it does mention on page 53, it does refer to the other strategies that are in there. The climate response team is mentioned, and there's obviously climate change implications. But even at the end of the report, it talks about the climate aspects. That's on page 56, but doesn't mention air pollution in there, and I think it needs to. So that's one factor that I think we need to sort of build on as well within that. Otherwise, great report, I absolutely support it. One other thing that's probably come more to the fore, but has been known about for a long time, is the actual kind of food that people are eating. I mean, we talked about the breastfeeding initiative, and as they move on to solid foods, we all know about mashed bananas and sliced up bits of cucumber for children, carrot to chew on as they're teething and all that stuff. We're giving them really healthy food when they're 6 months to a year old, and suddenly the chips and nuggets kick in at some point along that route. But one thing, and it's been mentioned a number of times in the press, is about the processed food. And the evidence now is accumulating more and more about how bad processed food can be. And a lot of our children, including my own, I'm guilty and I do it myself as well, we eat too much of the processed food. So I think it would be nice to see something about that in there as well. But so those are my two key comments. Obviously things like active travel and stuff and the relationships with the other strategies, and we've mentioned that a few times. Thank you very much.
Alti, please.
Thank you again, and I appreciate that this report is for noting. also appreciate the comments, James, you made earlier about the place-based work. So taking all that into account, the only thing that I would add is, again, from the system perspective, as in ICS system perspective, a joined-up approach across Kent and Medway would benefit all our residents and will contribute towards the ICS strategy as well. So we would welcome that joined-up approach, and of course we are going to have offline conversations about that too. Thank you.
Anyone else, James? I think you wanted to come in.
Thank you. Just to Malty's point there, clearly, again, it's one of those areas that we know, because the macro factors of, some of the wider determinant issues, Scott's referenced it, what we put in our mouths and what we do physically, they're important, really important elements of it, but actually there's a broader system thing. If you're employed on a 0 hours contract, you've got to get from A to B at whatever time, you're working 12 hours on a shift, you get out of work, what are you going to do? So the context there is we need to tackle this problem at a whole range of different levels, and not least, clearly, we will definitely ensure, and we've got that where people have got significant weight challenges that need clinical interventions. We've got to make sure that we get all that right and collaborate and get some equity across a piece. I think that's right. But when we go back to neighbourhoods and little communities, and when we look at our geography and we look at the interactions between wards and places, we members, you can see, and most disadvantaged communities, the weight pyramids are higher. So the reality is, if we don't work at lots of different levels to find different solutions that are bespoke for those particular challenges, and we just talked, didn't we, about our women, and we want our women to breastfeed and to be able to engage and bond with the children. Weight is a significant issue. It was in there in Scott's list around all of those factors. So we've got to, we've got bespoke programs, to be fair, to support women to lose weight, obviously during potentially so that they don't put it on below supposed. So what I would just remind members is this is a whole systems piece. The eating stuff is brilliant, and we really have got, Scott hasn't mentioned them, I know there's some bits in the paper, but we do try and build on, the resources that we've got within Medway to support our communities. But this is not going to happen overnight. 69% adults 18 plus in Medway overweight or obese. It's a big number, and that didn't happen overnight. So likewise, I refer us back to the things that we have been celebrated on and got shortlisted for. Scott's not going to say this, so I will. Our Medway Can programme. Leanne mentioned the community's ability to engage over 3 times around the world. Schools fully engaged, working with us, using their own buildings, facilities to bring families in to those settings to work with them around these types of issues. So we've got to just remember, it's really important, the stuff that we put in our mouths and the activity that we do, but this has got to be layered, and that's why Vicky's job is so important to us, and she can't go anywhere. Just tell you that.
Dee and then Tracy, and just before you both speak, I think, look, we do an enormous amount, and at 3.4 there you can see all the little things that happen lots of times across Medway to try and help and encourage people. We've got a new policy for food at our events, trying to encourage people who come along to offer healthy options and really, line up so that we haven't got, as people will have heard me say many times, at the Armed Forces Day, public health cooking grilled chicken and pineapple salsa opposite someone selling foot-long hot dogs for a £5. That isn't helpful. Had a great participation in the Medway Mile event, actually, which I think shows that if you get the tone of an event right, people will happily join in. And I think everybody that walked that mile, it might not be very far, but walking along with all sorts of people of all kinds of shapes and sizes and fitness levels, people, including people in wheelchairs, really, made me think about that inclusivity and people feeling supported to do something. And we've got our healthy walks and walks in the park, and members of the council, you can follow mine and Councillor Edwards' lead. We've started off a walk in the park in our ward. If there isn't one where you represent, that's something that you can do, and just, you know, helping people start slowly getting other people involved. So these little changes do stick eventually, but again, it's careful balance, isn't it? It's wanting to make people feel that they can achieve a healthy weight for them, and the things that they put into their body are things that are going to make their body work properly. And I think, you know, getting the balance and the language right about that, and not doing fat shaming or, you know, making people feel it's their fault. And always, we've got this huge challenge with food. You know, I'm always absolutely shocked by the fact that if you buy 6 apples, they are twice the price, still, even with inflation, of a packet of fish fingers and a bag of chips. And that's, you know, that's what people face. I know we've got fruit in schools, and we've got free fruit, but if you're going around the supermarket, that's what you're looking at. You know, a bag of apples, often, you know, £3.50, £4 sometimes. I've seen them lately. Packet of cheap fish fingers and a bag of chips, less than that. And, you know, families are making choices about what's going on the table, what's going into the lunchbox, and you know, everything that people have said earlier about cooking from scratch and not having processed foods is important, but we've got to find identifiable ways for people to join in that at a time when it's tough to do so.
This really follows on from some of the things that both James and Teresa have mentioned. First off, the availability of food. If you're in a hurry, if you're a busy person, there are so many fast food outlets. And this covers a lot of areas. It's choices parents make, but in our planning, we need to be really thinking about how many planning applications we agree when new people come forward wanting to a change of use to another fast food outlet or a hot food takeaway. We need to think about our own events, as Teresa mentioned, and making sure that we're offering healthy options to people as well. But we don't want to take away choice. We want to increase choice for people so that they can make those healthier options if they prefer. We've also got our School Streets initiative, which is being brought in, which is going to help improve air quality, but also if that encourages parents to leave that car at home and actually make the whole journey on foot instead of parking a little further away and walking that bit in, that will help too. In the discussion that we had about breastfeeding, we talked about Healthy Start, which gives a financial help to parents on benefits up to the age of their children reaching 4 years old. We've got a better uptake than nationally, but we still have more than 1,000 parents who are entitled to this who are not taking it up. And we know that we now have a tracker in place where we can identify individuals. All these small steps add up to help improve the health of our children and to help reduce obesity. So I think it is a case of looking at all these different things and bringing them together, because there's no one answer to this issue. We've got to bring a number of different areas into play here.
Tracy, Eddie?
Well, again, I think culture's got something to, relevance to this. And thank you for James for saying what I term a reality check comment. I really value those. You know, this is reality. Back in the day when, I'm not going to say good old days, by the way, but back in the day, possibly in a family network, if the mother of the house was doing a 12-hour shift cleaning, comes back exhausted, she might have had a mother around that would be cooking the meal. So we need to recognise these changes in some communities, because there are other communities where they still have a very strong family base, and I think that's significant. I also think one of the worst things ever is when, not when I was younger, I didn't think this, when instead of school dinners being paid directly by my parents to the school, they gave me the coins in my pocket. Oh my goodness, in school uniform, 13, 14 years old, buying cigarettes. Just this, you know, the person selling me cigarettes, no regard. Living off sweets, biscuits, rubbish. I didn't go anywhere near healthy food during the daytime. This, I think, also links into something which I cannot see here. So a couple of weeks ago, I had an interesting conversation with the pharmacist about my new medication, and he said that overeating, which is obviously one of the contributors to obesity, not the only one, it can be your lifestyle, it can be your medication. My daughter, when she changed her medication, ballooned, unfortunately, from a very slim young lady, somebody who's overweight. But he said that eating is an addiction. And I agree. I gave up smoking very easily. I can be with all of you sitting here drinking alcohol. I'm not bothered. Put food in front of me. I don't know why, but I cannot resist eating food. And I do think it's a very powerful, in a negative way, a problem which I would like to see openly recognised, that overeating is addictive. And it's not just the sugar rubbish. It's not just the chocolate. It's all types of food.
Okay, thank you, Eddie. Would anyone like to, Scott, you're going to respond to that?
Well, yeah, a number of factors. We just want to provide a bit of assurance from different challenges, questions, suggestions have been really helpful. So even though if it's not explicit around air quality, for example, just have confidence that a lot of the work that Vicky's been doing with James Sutton and the Safe Journeys team, for example, including the Green Corridors work, one of the things we've suggested, for example, is next time we choose the next cohort of schools, can we factor in the obesity prevalence data? So we tackle both issues rather than choosing, lots of nice leafy, healthy weight kind of predominant schools. Can we look at areas where there is challenging? Again, you wouldn't be surprised, you overlay obesity with deprivation, you find that. So we acknowledge that some schools might not be able to do there, but we do try and work with all of our officers to see the synergy between what we do. And active travel is a huge one for us. Anti-idling campaigns, for example, how do we push the activity message whilst pushing the anti-idling message? Well, it's quite simple, obviously. Medway Can was a big programme of work for us over the last year. So in October, what we didn't want to do is to try and recreate the wheel. So the big push of Medway Can during October was encouraging as many schools to take up the Hedgehog Challenge and the other, I can't remember the secondary school education one, it's encouraging that active travel because it's an intervention already happening. Whether people are walking to school for air quality reasons or movement reasons, it's the same action we're pushing. So we are really clear about working with our council partners. One other programme of work that's going really well at the moment, our whole school food programme. So we've got over 20 schools now signed up working towards their at least bronze award, ideally aiming for gold. This is massively changing the turkey twizzler generation and what Jamie Oliver saw back in 2007. And it's about pushing that school, not just have nice menus, but to encourage better growing, cooking, eating projects. And 20 schools started that programme, and we'll be writing to all members in the next couple of weeks just to say, can you encourage as ward councillors, your local school to sign up? Because it's a free service that's available to schools. It's a programme of work, and we work with our Healthy Early Years settings. So 2/3 of our early years settings for our Healthy Early Years Award. A core fundamental part of that is healthy eating, cooking, growing, eating projects. So again, we provide free support to primary schools, secondary schools, nurseries and preschools, and we have from free resources around cookery to everything else in between, and activity programmes. Assurance and Multi, I co-chair the Kent and Medway Whole System Obesity Group with my colleagues from KCC, Abby Ojo, so we are always looking for opportunities to work collaboratively. Kent and Medway is a big place, so I'm not going to say we're going to have exactly the same services across all those areas, but we're talking to them at the moment about potentially having a shared healthy advertising policy that both councils could collaboratively sign up to, and that just shows that joint working. Just before we started the session, I sent to council to carry around how do we have a local plan. We're going to host a local plan workshop on health and wellbeing, particularly. So it'd be fantastic to have portfolio holder opening that and talking about the opportunity to build in healthy weight and build out an obesogenic environment, and how do we do that, as well as the other core health and wellbeing agendas. One plea from me, what really helps us as officers, what really helps me and Vicky, is if members can remind their ADs and portfolios and service managers that this agenda is equally as important as the events agenda, that this agenda is equally as important as the grain travel agenda, because we're talking about the same thing, we're talking about the same aspiration. What's really helpful for us is directors of NHS partners talking to their service managers and junior officers saying, when you think about your catering offer, think about health and wellbeing. We will go and enter that space, we'll go and do that for you. But if you guys can open the doors for us, we can go and have the meaningful conversations to show that health and wellbeing can complement all the other agendas.
And perhaps just the final point, we need food, don't we? We do. There's a reason why the manufacturers make it tasty. And the context of that, and I think you make some really important points around just that relationship that we need to have with food. It's hot now, you know, I'm sure that most people, as long as you might have a dairy challenge or whatever else, but you might have an ice cream or whatever else, fine. But the context for some people is, if that's the only food that they're eating, if it's the high calories, high fat, high salt type, that's the challenge that we all face. I do think, and you're looking at the list, if you haven't had a chance to go out and have a look at some of our programs in practice where we're working with our community groups, then take the opportunity, and that's all members of the board, and share that with other colleagues. Just go along and see, because we do that piece, which is to get the food. We've got chefs, trained chefs, but also we've got other colleagues who are well trained up in terms of food nutrition. Show people exactly this is how to make that nutritious taste. Because if you look at the macro level, central government, they've been working, haven't they, with food producers, I won't mention people, but cereal producers that, their breakfast cereals are as 3 jars of sugar wrapped up with whatever. So they're working at reformulation, doing things, but we can do that ourselves and still get the same taste, but without the additional calories, unfortunately, that might come along with that. So I would just encourage members to, where we're running these programs, even we've just had a half program out now, just go out, have a look, sit down, book yourself onto one of the courses, they're free. There isn't a cost to them, and that's part and part. I say they're free, obviously, the resource, but they're free to the user, because we recognise that some people need a bit of support, and we try and tailor that. One thing Scott's mentioned, and it's referenced in here, is our Start for Life hubs. So again, that's one of the opportunities that we've really got to work with some of our communities who potentially might need a little bit more support than some of the other ones. But yeah, there's a big macro agenda, and for all of the, which I'm not, of course, our politicians, it's the pushing up to central government to ensure that they understand the impact of those national policies on us down here that have to then work with the challenges that arise out of those issues.
Yeah, I think we've got to fight on all fronts, haven't we, for this? There's no question about that. So for members going along to your schools, we can easily get those lists out of people participating, going along to look at some of the great little cookery programmes that are offered in the community. We haven't got enough of them, no doubt in my mind about that. And when we had the Shore Start Centres all up and operating, there was a lot more of this stuff going on. There is a political element to this, and we've got to, Tracy and I had a very positive meeting with the early years team last week, thinking about, how can we make best use of the facilities that we've got now, and what are we not doing that we could, within our constrained cost envelope, change, and nothing's off the table as far as this is concerned. And we've got our food partnership event excuse me, coming up in November, together with something we agreed at Cabinet this week, a refreshed approach to the Household Support Fund, so that we make sure that the food partnership is dispersing money for good food to as many people who need it as possible. And a new initiative that I'm starting to explore, initially from a sort of political point of view, but widening to public health, is to have a community shop in Medway. In other words, trying to work in a different way to move people away from food banks and into an arena where, and these are quite successful elsewhere, there's lots of them around, you pay £5 and go into the community shop where surplus food is stored, ready for distribution, and pick the things that you want with advice going alongside it about what's healthy. I think one of the tragedies of food banks is that, first of all, that there's all of the stuff about need and dignity associated with them, but also, for many of them, having to have what you're given, which might not be something that you want. And it might not be something that you've got the facilities to to cook either. And I think just trying to move people into a space where they can make those choices and feel like, you know, that's something that they're doing themselves for their family, back to Leanne's point about services, rather than something that is being given to them, it is really critical. And we've got to just gently change some of those things and bring along our local organisations with us to you know, perhaps also think about different ways of doing things. Yes, Eddie. Excuse me.
You need some water. No, I was just thinking that thing about advice. I mean, I hate the idea that you lecture to people. I can't stand that myself. But giving an advice. So where I work, mental health, I have people that I have this sort of conversation with a lot. And sometimes it's just putting the idea into their minds. And it's not just because of the way that they are, but for all of us. And just to give you an example, because I'm going to show off now, because I used to be so lazy. It's not a big deal, but for me, this morning when I had cornflakes, I added seeds, fruit and nuts. I've now got a much more tasty, fulfilling breakfast, and I'm glad that I've got into this habit that I'm bothering to do that. And you may be thinking, oh, that's no big deal, but it's not. You know, I used to reach for these sugared flavoured cereals. They are now banned from our household. And it's habit forming, isn't it, a lot of this? So I'm glad to hear about the initiative, by the way, where they give advice. Because there's going to be a lot of wasted food when it comes to food banks. Like you say, people getting items that they don't even want, so what happens to them?
So full marks to you, Eddie, for taking some of the advice that you've got on offer already. We're pleased about that. Anybody else? Critically important part of our public health strategy. So I'm looking at the recommendation at 1.1. And I think, again, Steph, we've had lots of ideas about how we can help deliver that whole system approach to addressing obesity. And certainly, Vicky and whoever's relevant to, I'd like to involve you in some of the work I've been doing with other authorities about these community shops. I think it's, you know, something we could achieve in the Pentagon actually quite easily, since we own it, and just kind of reconfigure perhaps things a bit, but for an offline conversation initially, please. Okay, well that's that recommendation, so thank you everybody. Everyone happy with those? Okay, and the last part of the agenda, pretty well on time. Anything anybody would like to add on the work programme? Steph says she is happy with it.
I'll just say one thing.
Okay.
Really. Just for the people that weren't at the development session, details of that can be found at Appendix 2. And James may want to say something about the addition at 3.21 for a suggestion that he made for women's health to be added to the work programme, and also the major condition strategy as well.
Mm-hmm. James?
Thanks, Chair. And just we did allude to it. So on the women's health, a couple of years ago, the central government published a women's health strategy. But one of the things that we want to do is to make that live and real for our local population. I along with Malty and other colleagues within the ICB, are now looking with the medical director as to how we can deliver a system-wide women's strategy. But Councillor Murray's also tasked us to make sure that we make that relevant at a place level. So we'll be coming back to the board just with an overview of that strategic landscape, what that looks like, and then trying to just unpick what that might feel for us and the real bits, because I think I've heard already Councillor Hackwell as well as Councillor Peake have said, and the so what question, we've got all this stuff, how can we actually make sure it makes a difference? So through this process, hopefully the board will be able to have a look at the things that really matter and important to our women, and let's see what we can actually do to deliver it. So we just want to bring something back on that one. The major condition strategy, so this was something that was published just 2 weeks ago, and it's an NHS strategy, but it's actually not an NHS strategy. It's a strategy to deal with non-communicable diseases in the main, or the risk factors that relate to them. Including, we know what they are: cardiovascular disease, cancers, that type of thing, respiratory disease. So again, it would be to bring that paper back into the board and to identify the things that we are already doing. So some of that would be just saying, right, and actually, because we've had a debate today, obesity. So obesity, type 2 diabetes, hypertension, they're things that are in the major condition strategy. We'd be able to sort of talk through how we can make those alignments. So again, it will be to give the board oversight of those 2 key programmes of work, highlight some of the challenges that we think that we might face, and then look at a system level, clearly as the board as to what it is that we can do or are currently doing that might need enhancing to deliver some of the outcomes that's set out in those papers.
And I think, Matt, as well, at the last meeting you mentioned about bringing the clinical strategy. And did you know when you wanted to bring that at all, or wanted to say anything about it?
Yes, I did. We are taking the draft of it to our board in October. So there's been a bit of work around the format of it and things like that, but the majority of the work is completed underneath it. So at that point, we will then circulate it to partners here to have a good look at and pull it to pieces and make sure that it dovetails with all the things we've talked about here, which would be excellent. As with all these strategies, it's not set in stone, so it will be very much a dynamic document. It's a sort of 1, 3, and 5 and 10 year piece, as you would imagine, and obviously it gets a bit more aspirational towards the upper end of the 10 years. Yeah, it's there, and as I said earlier, we're viewing this, yes, it deals with the workings of the hospital and sets a strategic direction for that. But we really have turned it around so it has an outward-facing lens too, to make sure that it actually starts to cover a lot of the things that we've talked about here. So, as I say, it's a complementary piece rather than a standalone. So, absolutely, we will share that as soon as that draft's been through our internal governance process. It'll be ready to come out here.
Okay, thank you, Matt. The only thing I would say, Steph, is February looks very heavy compared to April. And I wonder if we might be able to move the Community Safety Partnership to April. Would that? Particularly as we've got the annual report coming from you, James, it might make sense just to rebalance.
I'll discuss that with you.
Okay, thank you. So is everyone happy to accept the work programme? And with that, thank you very much, everybody. I thought that was a really helpful and insightful meeting, and we've got some good things to work on. Okay, thank you.